Good morning, good afternoon, everybody. I'd like to welcome you to Foley and Lardner's Access to Capital program, where we're very happy to have a number of people calling in today. This is the first webinar in an ongoing series focusing on capital formation for hospitals and health systems and provider organizations. It's going to run through the fall and culminate in a day-long in-person event on the topic in early 2013. And today we're honored to have with us three experts, each of whom has been working in this area for 25 to 30 years, and who bring with them a variety of perspectives and backgrounds in this topic. They'll talk about the current climate for hospitals and providers seeking to raise capital and the opportunities and challenges presented through health reform, with a particular perspective from Massachusetts' early entry into the health reform. Before we begin, let me go through some housekeeping and logistics here. If you're online, you'll see on your screen, if you need some technology assistance, you can call 866-493-2825, and dial *0 if you need some audio assistance while the webinar is ongoing. On your screen, there is a Q&A tab located on the menu bar at the top, and you can enter questions there, and we have set aside a good period of time for questions and answers at the end of this program, because we're hoping to have some good interactive discussion both among the participants and the people that have called in. And we do feel free to maximize your PowerPoint. You can hit F5 on your keyboard or under the view on the toolbar menu and click full screen to fill out your screen. And you can also print a copy of this presentation by clicking on the printer icon on the lower right-hand corner, convert it to PDF, and then print as usual. We are going to be applying for CLE credit after the web conference, and the information for getting CLE credit is, the email is eharris, E-H-A-R-R-I-S, @foley.com. We will be putting all of the materials online after the presentation as well. My name is Adria Warren. Before I launch into the speakers here, I'm a senior counsel in the healthcare practice of Foley & Lardner's Boston office. I specialize in business affiliations and acquisitions and other transactions. I'm going to introduce the speakers in the order in which they're going to speak. Keith Pitts is currently the vice chairman of Vanguard Health Systems. And Vanguard owns and operates 19 acute care hospitals and related outpatient businesses in 5 primary markets. Keith crosses a variety of industry sectors and functions, including strategic planning, organizational development, operations, finance and information systems, and M&A. And prior to joining Vanguard, Keith was the chairman and CEO of Mariner Post-Acute Network and its predecessor, Paragon Health Network, and also executive vice president and CFO of Orinda Health Corp. And a partner in Ernst & Young's healthcare consulting practice. David Siganowski is the managing director and head of the New York office of Kaufman Hall, which is an independent consulting firm that offers integrated strategic, capital, and financial advisory services to hospitals, health systems, and other healthcare organizations nationwide. David has specific expertise in capital finance, strategy, M&A, and strategic affiliations. David was formerly the managing director and co-head of the healthcare group at Citigroup Global Markets. And prior to that, he managed the healthcare practice at Credit Suisse First Boston. He was also an architect of the annual nonprofit Healthcare Investor Conference, which is jointly sponsored by American Hospital Association, Healthcare Financial Management Association, and Citigroup. And Chris Doyle, our third speaker, is a managing director, and she heads the healthcare practice for public financial management. Chris advises on capital market strategies and market access, capital and strategic planning and structuring models. And from her base in Boston, Chris is able to provide a firsthand experience and perspective on the Massachusetts reform experience. But first, let me introduce my partner, Mark Waxman. Mark is a partner in our Boston office and the former chair of Foley's National Healthcare Practice. His practice focuses on transactional, regulatory, and contractual issues for both for-profit and not-for-profit providers and payers. And his previous business experience includes service as the president and general counsel of the Care Group Healthcare System. So, Mark?
Thanks, Adria. Very much appreciate those participating today, in particular our speakers who have a long and diverse industry experience and will bring a lot to the discussion and hopefully provoke a lot of thoughts among our audience. It's my job to kind of warm up the crowd, so to speak, for their presentations and talk about sort of the framework or the context in which we now ask this question, where do I get money and how much money am I going to need as I look forward into the future in terms of operating our hospitals. One of the key things to think about as you think about money is, what do I use it for? And this slide is one that I've used to present to hospital boards who are interested in looking at an awful lot of statistics and try to bring folks back to, what it is we're actually talking about on the ground. And that context is this. If you're obtaining money and operating a facility, keep in mind that, the building is going to be there for 25 or 30 years or more. And so one planning horizon in terms of capital access is to think about, I'm creating a structure that's going to be around for 25 or 30 years, likely more with the planning that I'm doing. If I'm thinking about outfitting that structure, I'm talking typically about leasing, the integrated equipment part of it. That's going to be a 3 to 6 year effort. So I'll need to think about financing that out and paying for it in that sort of time frame. I think about my contracts with payers, the payer side of the equation. If you think about how much that is, if you add up Medicare Advantage, commercial workers' comp, and some other contractual arrangements, these contracts run 3 or 4 years. Sometimes they're year to year, but I think let's call it a not atypical contracting cycle might be 3 or 4 years. I think about physician recruitments, significant physician recruitments in order to build and diversify my base as I think about the future. To put a physician in place, it might happen in a week, might happen in a few years, but I think a general cycle might be a 2-year process to find, recruit, bring in-house, and start up, a physician. And then we face a situation where, open enrollment is every year. So we have, on the Medicare side, you can have a fair amount of fluidity. You can have enrollees who, as a result of tiering or other relationships, might actually move the business, even if the physicians don't, create pressure to move the business. And that's something, people need to think about, notwithstanding the managed care contracting cycle every year. And then I'm also sort of called to mind that the phrase, no man's property is safe while the legislature is in session. The legislature obviously meets most places every year, and so changes can also occur relatively quickly on the legislative side of things. So that's our general framework from a time chronological perspective at how we think about operations. The second way we think about operations is, we want to have a healthy organization. And I found this definition in Health Affairs a decade ago as different sorts of financial challenges were on the table, but I don't think the goal has changed at all. We want facilities, physician practices, suppliers to produce an operating margin. That has to be sufficient to finance current and future capital requirements. We have to get the capital necessary for maintenance and growth, and there's only a few places this is going to come from. It's going to come from operating cash flow. It's going to come from financing, whether on the for-profit or not-for-profit side. And on the charitable side, charitable contributions or an endowment, which you might think of, is it essential or extra? Kind of depends on where you are. But I think the general definition of what we need to operate a healthy organization is set forth here, and that helps drive our finance and capital discussions. Now we turn from that sort of framework to what is it we're thinking about in the market today. The economy, you could go up, you could go down on this particular point, but by and large, it looks kind of flat. So on the overall economic side, if we assume things are flat, we're probably not going to be too far off one way or the other. Translated into hospitals, admissions are flat. Some are up, some are down. I think you read some of the reports, they look kind of flat across the board, notwithstanding the aging population. I don't know that anyone thinks admissions are going to zoom on the inpatient side one way or the other, query the uninsured, which we'll get to. Revenue growth, I think the reports over the last year that look forward say this is going to be challenged, whether you look at S&P, whether you look at Moody's, Fitch, or Kaufman Hall. This is going to be a challenge in the aggregate, particularly on the inpatient side, and that's a result of lots of things. One of the things that's going to challenge revenue growth is premium regulation and employer pressure on premiums. Whatever you do, if you stop the spigot at the top, namely the amount of money going into the system on the commercial side, then you're going to be constrained on what comes out at the bottom on the revenue side for the providers. That's one reality. A second is, Medicare cutbacks. Whether the Supreme Court rules one way or the other with respect to health reform, I think we're going to be looking at Medicare growth on population is one thing, Medicare growth on payment amounts is something else. We have cutbacks, coming, whether it's dish payments, whether it's readmissions, whether it's the market basket, however one looks at it, between health reform, a sequester, or other legislative activity, Medicare is not looking to be a revenue enhancement on an individual patient basis. Provider rate regulation is coming back. Maryland has one program. Here in the Commonwealth, the legislature is considering, as we speak, provider rate controls and a rate apparatus. It was attempted once before. I don't know that people think it was all that successful. If we look at where we are today, I guess you'd say it wasn't all that successful. But the legislature, together with the Attorney General's office and the governor, are now moving forward towards provider rate regulation. We'll see what comes out of the hopper. That's likely by the end of July. And then we look at the payer mix. And what I've shown you from 2009 to 2011, nationwide, the Medicare portion is going up. The Medicaid portion is going up. In the aggregate, you're now looking at getting closer to 60% of that population being government supported one way or the other. A big question mark, the uninsured. If health reform as it currently stands continues, then we'll see one aspect of what happens to the uninsured. If it ends up going away, it doesn't eliminate the uninsured problem, whether that has to be dealt with directly or indirectly through EMTALA or other mechanisms, kind of remains to be seen. So as we think about what today's elements are, then you say, well, what else is there? And there's other stuff. The cost pressures from wages won't go away, technology, pharmaceuticals, what it costs to build things, those costs don't seem to be going down all that much. The price of steel, for example, and labor in that factoring isn't going down. And in financing costs, I'll let our panelists talk about this. Financing costs have gone down. Rates are not what they were. We don't know for how long, but those on the phone can certainly address that better than I can. If we go out and we ask people, as opposed to look empirically, just ask members, C-suite members, what they think is going to drive costs, a variety of answers. Healthcare legislation seem to be the highest. Other people might say disagree and think it's labor, because the labor component is a much more significant day-to-day component. But you can see that none of these drivers, if you go down this list and say which of these are going to go down, I suppose you could say ACOs may, emphasis on may, help the lack of clinical coordination, but they're certainly not coming overnight and are untested in terms of their overall impact. Overutilization, query whether bundled products and services payment mechanisms will make a material dent. Again, the Commonwealth here is going to experiment with that particular element. But you see, as you go down these, most of these drivers, again, are towards, the increased cost side of the equation. So what are people doing about it? Everyone says, well, one thing I can do is I can try and increase revenue by increasing market share. And the way I might do that is through mergers and acquisitions, through physician recruitment and employment, particularly on the primary care side. I'm going to make sure I'm paying attention to my receivables. I may come out with more focused factories, focus on cardiology, orthopedics, but, you know, as we've seen with cardiology in particular, I can do that for a while, but, you know, it's no for certainty that it will stay that way. Changes in technology and payments, you know, may end up gutting what you invested 3 to 5 years of an equipment cycle or 25 years of a building cycle into. So on each of these, one needs to be careful about how high margin services are going to last as high margin services over the period of time in which they're housed in a building. Debt restructuring, a lot of people have obviously looked at that. It's kept everyone pretty busy on that front. Or I can just sell assets to raise cash, but I'm not going to be able to do that more than once or twice. So with that in mind, you know, that's the framework in which we're looking at things. Let me now turn it over to Keith, who will tell you from his perspective and the for-profits side how they're addressing these types of challenges. Keith?
Thank you, Mark. I appreciate it. Well, a couple of things, but because access to sustainable capital seems to be an issue for a lot of hospitals, and just by background, we're a 15-year-old company whose strategy is to acquire or partner, that is joint venture or otherwise, with multi-hospital not-for-profit systems in urban and suburban markets to really anchor the development of regional integrated health delivery networks. So since the introduction, we're actually up to 28 hospitals, but it didn't happen over the last 17 minutes, but in 5 states. So again, continuing to grow in states we're already in, like Texas, and of course, that includes the Detroit Medical Center. I would echo some of Mark's comments about, you know, the environment. We get asked by investors on both the equity and the debt side, on the for-profit side, all of the time about what happens with the Supreme Court, and our response is simply there are 2 things that are never going to go away in the debate here in the country until we have a solution for them. One of them is actually coverage, which is what most of the Affordable Care Act is about. The other is entitlement reform, which you could translate into payment and delivery reform around Medicare and Medicaid. And our belief is none of those really go away. You know, no matter what happens, it's going to be enshrined in the debate forever until we get to some kind of a solution, preferably bipartisan, on fixing some of these things. And I think so. You know, if you believe there's a possibility the Supreme Court can rule, or certain things can happen in the election, and everything's going to be smooth and stable and not very volatile again, this is probably the wrong business to be an investor in. Having said that, there are a lot of things that, from a capital access standpoint, that we've had a good run on the investor-owned side for a while. You know, the debt markets have been fairly favorable and are generally not as volatile around things like, you know, what will happen with the Medicare rate cut or what will happen with healthcare reform. Where you see a lot of the volatility in the investor-owned sector is in the stock market around uncertainty. So effectively, bad news, which can be modeled in, is better than no news or uncertainty. And I think we're seeing a lot of that. And in fact, the sector is trading near the levels that I haven't seen since 1993, when Hillary Care was a threat. So that only really affects those of us in the investor-owned sector that are public, only if and when you really need to issue more equity or sell equity in any other way. It doesn't really affect, generally, the access to capital if you have plenty of capacity for debt leverage, and it doesn't really impact the business per se. It doesn't make you have to change your business strategy. So it's one of those things that you just have to live with, and certainly investors would be happier if that wasn't the case, but it clearly is. What we see when we talk to, and I think now we see a growing number of boards, and I know David will go into this in more detail because they advise these kind of organizations, but when we talk to boards of not-for-profits that are looking for partners, their real concern has not generally been how big of a foundation can I create and hand out nickels in town. Most of them are looking for making sure that their health hospital or health system is positioned to be sustainable over the long term as this environment changes. And I think many people believe, as we do, that regardless of what happens politically in the next year or two, there are many market forces that are already in play and aren't going to reverse themselves probably at all. And depending on what does happen over the next 6 or 7 months, that being the Supreme Court decision for the election and then the first Congress post 2013, by the time you get through that, if, for example, the Affordable Care Act's mostly intact, then a lot of the train will have left the station on many of the initiatives and reforms. So a lot of those folks are saying, how do I prepare my system from a capital, from a market positioning standpoint in terms of scale, that's both a regional scale standpoint, and then from a risk management standpoint, how do I even become part of something that has presences in multiple parts of the country so I can smooth my risk or manage risk better for increased risk-based payment. And part of that's positioning the integrated networks of scale in your markets as high-value systems, and really trying to find a way and partners to help navigate the transition from fee-for-service to some form of fee-for-value. And I think that's a big concern by many boards now that are really forward-looking, i.e. have taken the time to think carefully about the future and not be just thinking about it when they're up against the wall and have run out of capital access or run out of steam from an operating standpoint or had some other event in the marketplace cause them to seek out a partner. But now I think we're seeing a much more long-term view. And then the whole idea of physician integration and what kind of capital that will require on top of what's already a very capital-intensive piece of the business, and that is the hospital piece of the business. So all of these things that I think positioning systems for the future and making them sustainable is a lot of the discussions that we tend to have these days. The other thing that I think everybody certainly shakes their head on, and this is, I think, clearly a burning platform, is there just isn't any more money. So the idea that, as Mark said, Medicare is, getting into a zero to minus mode, that the state legislatures every year or two, depending on when they meet, we've seen a lot of major movements in Medicaid programs, rate setting. I mean, the message here is very obvious, not subliminal. There absolutely isn't any more money, particularly on the government side. So I think the expectation that there'll be a reversal or windfall there would be a naive expectation. I think most organizations have embraced that. I think one of the views that I'd like to leave behind, I think, with the group, and certainly as we have questions, we can continue to talk about that, is that I don't believe that to develop integrated delivery systems, if you will, or networks of scale in markets and regions, that any one organization has to own everything. In fact, I believe that the perception of control that's been so prevalent in the hospital business by leadership over the years is a completely naive perception, i.e. if I employ the doctor, I control them. And truly, financial alignment, clinical integration, and around patient care is a much more powerful long-term view of, quote-unquote, of controlling your destination than the ability that if you could somehow get your hands on 100% control over everything, that you're going to be successful. And I think you can have control but not alignment very easily, and certainly not have integration or the benefits of integration. As a result of that, I think you're going to see a lot of hybrid structures in the future where you'll see, not-for-profits, and for-profit, say, non-hospital partners. You'll see for-profit hospital partners with not-for-profit hospital partners, and pieces of the system will be tax-exempt, pieces of the system will be taxable, but there'll be financial alignment and there'll be clinical integration, and everybody will ascribe to that. So I think I don't think we've seen all of the organizational models yet that we'll need to see to achieve success and to keep people at least within the zip code of their institutional comfort zones. And so I think a lot of folks will have to get out of their comfort zone for them to be successful in the future with forging relationships. But I do think there's more creative ways than just a merger or acquisition to create alignment and clinical integration as people start to build broader networks of care in different markets around the country. And with that, I'll conclude.
Thanks very much, Keith, for your comments. And David?
Well, good morning, everybody. And as someone with a firm that represents not-for-profit systems and hospitals exclusively, I wanted to go on record at applauding Keith Pitts and Vanguard, as we're going to talk about in a few moments. The healthcare industry, the healthcare delivery system industry, is in the midst of transformation, and it's a transformation that's going to require out-of-the-box thinking, creative partnerships between for-profit players and not-for-profit players. And we have always admired Vanguard and Keith in particular for their perspective, which he just shared, which is not-for-profits or for-profits do not have to own or control every element of the delivery system in order to evolve into an accountable care organization and develop the new core competencies. So our hats off to Keith. We are in the midst of transformation. I've had the good fortune of being in healthcare since 1982, and have seen and was around for the conversion from a cost-plus environment to DRGs. Was around for both BBAs, and those events simply cannot hold a candle to what we are witnessing today, and the transformation is going to hurt, as this graphic shows. We share a lot of the views that have been expressed by Mark and Keith already. There is not going to be, as Keith said, there's no more money. Healthcare systems going forward will be under extraordinary revenue pressure, and the pricing game, whether it was counting on Medicaid dish money, continued increases in Medicare funding, or the double-digit commercial contract increases, are a thing of the past. And we believe payment mechanisms are migrating even more quickly than people realize toward value-based approaches. And as a result of that, use rates, whether it's inpatient or outpatient, are going to decline as health systems move to become population managers. It's a manufacturing problem at its very essence. And health systems, in order to be successful in the new era, have to do more with less. And we're seeing as part of as one of their solutions to solve this manufacturing problem, they're consolidating at a rapid pace, horizontally and vertically. And even as we speak, the competitive landscape is being reshaped. And none of what's going on is dependent on the federal health care legislation or what the U.S. Supreme Court may rule or not rule in the coming days or weeks. There are much larger macro forces at work that have already been unleashed. So as systems look at what they need to compete in the new era, they're going to need a new set of core competencies, whether it's improved and increased physician integration, a higher coordination of care, rationalizing their delivery services, lines of services, being more cost effective, managing their risks. And at Kaufman Hall, we firmly believe that scale enhances the ability to develop these new core set of competencies. It's not the only ingredient to success, but it's a very, very important one. This next slide shows and illustrates very dramatically the correlation of profitability with scale. What we did was divide up the 400 or so hospitals currently rated by Moody's and arbitrarily, admittedly, put them into groups of hospitals that had revenues of $250 to $500 million, $500 million to $1 billion, which is the light green, $1 billion to $2 billion, which is the red, $2 billion to $4 billion, which is the blue, and the sort of odd orange color is $4 billion plus. And just to give you some sense of the sample size, there are 100 below 500 million, 100 between 500 and $1 billion, 60 between $1 billion and $2 billion, 36 between $2 billion and $4 billion, and 20 in excess of $4 billion. And you can see, whether you look at operating margin or total margin, the impact of scale for those organizations that have greater than $4 billion of top-line revenue, it's pretty dramatic. On an operating basis, it's 80 basis points. For total margin, it's nearly 200 basis points, or 2%. And one of the advantages and differentiating factors that for-profits have, and it's not by accident, it's by design. They've been believers in scale long before it was fashionable, but they enjoy greater scale than nonprofits. If you look at the left-hand side of this pie chart, the one on the left, you've got fewer than 5% of all not-for-profits have revenue in excess of $5 billion. In contrast, of those publicly traded for-profit healthcare systems, of which Vanguard is one, over 90% have revenues greater than $5 billion. And they've been able to, over the past decade, translate the scale into discernible financial benefits, just like those large not-for-profits have done. And when we look at the healthcare industry, a lot of people ask, well, isn't the wave over? And our response is, you got to be kidding me. It's just starting. The healthcare industry is more fragmented than virtually every other industry. This graph shows just how fragmented we are. In contrast to the airlines, for example, where the top 5 companies represent 63% of the market, and the top 10 represent nearly 84%. In the healthcare arena, the top 5 represent 16%. And to drive home that point even further, if you take one example of a very modest airline merger, Southwest and AirTran, and this is a baby one. It pales in comparison, ladies and gentlemen, to a Continental and United. But if you compare the combined market share achieved through the merger of Southwest Airlines and AirTran, and ask yourself the question, what type of similar consolidation would we need in the not-for-profit healthcare landscape to match it? It's staggering. It would take 11 not-for-profits to match the combined market share of Southwest and AirTran. And if you look over to the far right, these are not baby hospitals or community hospitals. We're talking about some of the very largest and most prestigious healthcare systems in the country. Mayo, Partners, North Shore, Long Island Jewish, Banner. So looking forward, when you look, though, beyond the numbers, what is it that we're seeing at Kaufman Hall? We're seeing a number of emerging consolidation themes. First and foremost is the emergence of super-regionals, and this is simply our term for the dialogue that's going on in virtually every part of the country right now between strong systems of like size. In other words, in the Mid-Atlantic, there are 2 organizations that have top-line revenue of $2 billion apiece that are both rated very strongly. None of them have a financial burning bridge, but they are in serious dialogue to come together in a full asset merger because they believe that when they match up their core competencies and look themselves in the mirror and look at themselves in an honest and realistic fashion, they face an intellectual capital gap and firmly believe that merging with an organization of like size will result in a healthcare system, will result in an integrated delivery system that is much better positioned for the future than if they were to remain independent. And the dialogue that's going on right now is going to result in some transformative announcements during the remainder of 2012 and 2013. Time doesn't permit going through each of these, but suffice it to say, there is merger fever going on, and we're seeing it well beyond just the super-regional theme that we just talked about. We're seeing independent hospitals in adjacent markets merging to form new healthcare systems, whether it's Catholic Health Initiatives and their St. Joseph Health System with the Jewish Hospital in Louisville to form a statewide system called Kentucky One Health, whether it's in Connecticut, which for the past 2 decades saw no consolidation, yet in the past year they've seen rapid consolidation with for-profits coming in and being a very constructive force. Danbury merged with New Milford to form Western Connecticut Healthcare Network. They just announced a letter of intent to merge Norwalk Hospital into that. So we're seeing strong independent hospitals coming together. We're seeing regional systems expanding their platform. And the Centera acquisition of Martha Jefferson is a very good example. Academics don't want to be left out and are moving aggressively to expand their footprint. And what really makes it fascinating, and we are convinced that this is a positive for our clients, which are not-for-profit healthcare systems, the for-profits are aggressive buyers again, and in retrospect, I would change the title of this page to say, for-profits are aggressive partners again, because as Keith pointed out, the for-profit companies in the industry are not don't have as their number one goal to own and operate 100%. They are very, very creative in developing partnerships and are very sensitive to the community fiduciary responsibility that boards feel, whether they're in Massachusetts, Illinois, or California. We also have new players, private equity, which helped get Vanguard started before they were able to go public last year, has invested $7 billion in healthcare alone, which represents a new source of capital for not-for-profits. Perhaps most interesting of all, and this is the reason why, even though I've been in the business 30 years, I'm more pumped up and fired up about coming into work every day, is the blurring of lines that we're seeing. I mean, over and above what Vanguard and HCA and the traditional players are doing, we're seeing a blurring of lines between traditional players, whether it's Highmark in Pittsburgh acquiring West Penn Allegheny, or this past week, which saw DaVita, which is one of the largest dialysis companies in the world, pay over $4 billion to acquire Healthcare Partners, which is a medical group in 3 states. The transformation that's going on is encouraging traditional players to change their view and to change their mindset and to change their business plan. And it's also causing new companies, whether it's a CareMore, which was a primary care physician group health plan in California that was just acquired by WellPoint, or Walmart or Walgreens to enter the market. So the takeaway is that there is an awful lot going on in the industry. And as frightening as it could appear to some independent community hospitals or mid-sized regional systems or large multi-state hospital providers, there is an overabundance of capital. As Chris will speak to in a few moments, we do have 2 different worlds right now. While rates are low, as Mark Waxman pointed out, we increasingly have the world of haves and have-nots, where higher rated, larger and stronger performers, like Partners in Massachusetts that Chris is very familiar with, or Duke Health in North Carolina, enjoy very good access to capital and an extraordinarily low rates. Conversely, though, we're seeing lower rated, smaller, weaker performers having trouble. And the past 2 weeks actually have been a vivid memory and has been a reminder of what can happen when access to capital for these lower-rated, smaller performers gets tricky, because there's been an awful lot of new issue volume by hospitals, and some of the lower-rated hospitals have had difficulties getting their deals done, and when they do get them done, they're getting them done at much higher rates. In contrast, the for-profits are living large. They've got broader and deeper access across more investment classes, with less sensitivity to credit ratings versus not-for-profits. They've got very inexpensive debt. They've got access to private equity. And when you look at the equity research analysts that cover publicly traded companies like Vanguard, the buy ratings from them are nearly double today what they were a short time ago. So from our perspective, not-for-profits should be looking precisely at tapping into for-profit capital, which is clearly available to help fund their growth in new and creative ways. The elephant in the room, though, is the value proposition. The model that is proposed between a not-for-profit and for-profit has to offer a value proposition that works not only for the for-profit, not only for the not-for-profit, but the communities that are served by the not-for-profits. And we believe, and we see it every day, that structures are being designed to create wins for all these different constituencies, and agree with the comments of our earlier speakers that you ain't seen nothing yet in terms of some of the creative partnerships that we're going to see in the future. It's only going to get better and more creative, which is a plus for our not-for-profit healthcare systems, because one thing is clear: in order to get ready for the new era and to develop this new set of core competencies, they're going to need dough. You need dough, and the dough is available, but it's going to come in a different way and from different areas of the capital markets than before. Now, this next page, first the caveat and a comment on style versus substance. While I'm born and raised in Chicago and by birth was a White Sox fan, I moved to New York in the early 80s, before cable and satellite TV. And after living there for about 10 years, I decided I had to adopt a local team. I chose the Yankees, not because they were winning at the time. In fact, it was the Mets that were the more exciting team. But I have turned into a diehard New York Yankees fan. And I know that simply is probably going to cause a handful of people that are on this call to simply hang up because you're part of the Red Sox nation, but felt compelled to use the bookends of the Yankees championships of 2000-2009 to point out the examples of the creative not-for-profit partnerships that we're seeing every day, whether they're management contracts, acquisition of non-core for-profits, sector monetization, conversion, sales to for-profits, partnerships with not-profits. And this next page, we provide an example, just a handful, whether it's Vanguard partnering with Detroit Medical Center in Michigan, or Catholic Health Partners working with Health Management Associates, or the Novant Health acquisition of MedQuest, which was a national imaging company, or as Chris will talk about in a few moments, the Cerberus investment in Stewart to acquire Caritas and other systems and hospitals throughout California. The warning that we would have is a reminder from one of my favorite shows, which I think points out my age, because when I showed this to my 16-year-old son yesterday, he had no idea who this person was. But I was a big fan of Hill Street Blues when I was younger, and Sergeant Phil, at the end of his briefing of his street cops every morning, would say, "Hey, let's be careful out there." And that's a warning to not-for-profits that waiting too long can have fatal consequences. If you you don't have to look any further than the lower right-hand corner of the graph and see the Hawaii Medical Center, which waited too long and had to declare bankruptcy. So, in summing up, and before turning it over to Chris to talk about the fascinating events that are happening in Massachusetts, we would have one piece of advice, and that is fasten your seatbelts, ladies and gentlemen. Fasten them nice and tight, because change is here. The notion that a board or a management team can make a motion and second it to stick their heads in the sand is simply not based in reality. Fasten your seatbelts. Change is here. Get ready for it. Be proactive. And with that, on behalf of Kaufman Hall, we'd like to thank Foley for letting us speak today. And now we are delighted to turn it over to Chris for a perspective on Massachusetts.
And thank you, David. And this is Adria. Briefly, I'd just like to interject and ask the people that are viewing, or remind them that you do have the opportunity to ask questions, and we're going to have probably a good half hour at the end of this call to take questions from the audience. And you can do that by going to the gray bar at the top and clicking on Q&A, and then enter a question online there. So with that, I'd like to turn it over to Chris to talk about the Massachusetts experience.
Okay, great. Thanks a lot, Adrian. Thanks, David, very much. That was moving right along to get a little more specific in the case of Massachusetts, which started in on this journey. Now it's been about 5 years, and we can walk through and see some of the approaches that have been used here. The initial healthcare reform in Massachusetts really was focused on the access side. And the focus of healthcare reform when it first came down here, and what has been implemented over the last several years, really had two goals in mind. One was, and the chief one really was, to make insurance available and affordable to all residents. And that was really the main thrust. There were some seeds of cost containment in the original healthcare reform bill here in Massachusetts, and they really focused on trying to find data related to cost, and also to get shine a bit of a light to get some transparency on cost data, which really had been really a bit of a black box historically, and still is to a certain extent, but really over the course of the last few years here in Massachusetts, a lot of data has come to light in terms of provider rates and so on, that has, I think, laid the groundwork for what's going to eventually be health reform number 2 here in Massachusetts, which we focused on cost containment. And it really, that was not the focus initially. And likewise at the national level, as David kind of alluded to, and also Keith, the Affordable Care Act really didn't focus on that either. So just looking at the Massachusetts case more specifically, certain circumstances that we had here in the Commonwealth that probably set the table for reform, or at least reform Part 1, pretty well. Massachusetts already had very high employer health care coverage nationally, one of the highest rates of employer health care coverage in the country. So the magnitude of our problem percentage-wise was smaller than in many states in terms of lack of coverage. There was already a pretty generous Medicaid program here known as Mass Health, and also a network of safety net providers in different parts of the state. We did have, in the time leading up to the reform, rising premiums and rising and escalating health care costs. And the health care costs have continued actually to go up, and we can talk a little bit more about that. Premiums have definitely dampened here in the Commonwealth in the last year, but that's a recent development. The other thing that was kind of set the table for reform, I would say, was that there was increasing demand on hospitals for uninsured care, what we called the uncompensated care pool here in Massachusetts, and that was really escalating and was putting a big strain on hospitals, and they were demanding some potential solutions or changes to that program. In terms of numbers, it was about 460,000 people here without insurance. Then if we go to look at the elements of healthcare reform here, there are really kind of four key elements. And the first one had to do with the role of the individual and sort of trying to shift the policy concept was putting individual responsibility rather than on the hospital, so that adults 18 and over had to have coverage, and you had a penalty if you did not have coverage, if you do not have coverage here. And again, the goal is to shift the problem away from the hospitals with the uncompensated care pool and over to individuals, and through the vehicle of an insurance subsidy. Second component of the reform was employer responsibility. Employers with over 11 employees have to make a contribution to their employee coverage, or they have to pay a penalty, and in addition, they have to offer a pre-tax type plan or pay a surcharge depending on their employees' usage. So individual responsibility and then employer responsibility, the first two pillars. The third one was expanded insurance options for individual purchase, and that's a program here in Massachusetts known as Commonwealth Choice, and it's available through what's known as the Health Connector, which is an exchange-type concept that you've heard about discussed nationally. There are different levels of those products available that can be purchased, as I said, either directly or through the connector. And certain insurance adjustments to our insurance laws here in Massachusetts were made as part of reform in an effort to make a pool more broadly, really to distribute risk and to have premiums based on a broader pool of individuals. The fourth pillar was governmental subsidies for low-income residents, and that was really expansion of what I already referred to, the Mass Health program, or our Medicaid program here in Massachusetts. That was expanded for children, and in addition, there was subsidized insurance for low-income individuals for adults created, Commonwealth Care it's known as. So those are sort of the four pieces of healthcare reform here in Massachusetts. The font is a little small here, but in terms of sort of policy results, before we look at sort of what's happened to the market more generally, basically 400,000 additional residents with insurance, which I think puts Massachusetts at the highest insured rate nationally, about 98% for adults, 99% for children. Depending on the data you look at, race and ethnic disparities in access have dropped. They certainly haven't disappeared, but they've dropped. And most of the increase in coverage has come for low-income adults. The small number that remain uninsured is mainly a population of young single men that are low income, that makes up the sort of 2% there that is still being missed. In terms of the increase in insurance, it's come from a combination of those two state-related Medicaid, Mass Health, and Commonwealth Care, which is a subsidized state program, and about 20% or so from individuals purchasing commercial insurance. Employer insurance remains dominant in Massachusetts and has risen somewhat, 79% of insured, still very high nationally. and actually compliance with the individual mandate is quite high. So there are certain individuals that are exempt from the individual mandate here, but in terms of the folks that are required to comply with it through tax filings and so on, it's actually quite a high rate of compliance. There hasn't been a lot of crowding out, i.e. private employers dropping their insurance for public insurance. That's a slippery analysis, but generally speaking, there hasn't been a lot. But at the bottom, of course, as I brought up at the beginning, costs have not been contained, and that's really the big that's the big kind of kahuna that has to be tackled and the most difficult thing. If we move over to some, let's see, I think I went too far. Some of the changes that have been taking place in the market, making more specific some of the general things that David was referring to, we see really multiple alliances and affiliations and mergers, and it's really has not been, as David alluded to, just an old-fashioned merger, just come together that way. Really, we've seen a lot of interesting alliances, public, nonprofit and for-profit entities coming together, whether it's at a programmatic level for a certain line of service, whether it's upstream or downstream, say with pharmaceutical companies or with pharmacy chains themselves. These are some of the types of alliances and joint ventures that we've started to see here that I think that is going to continue to be spun out in the course of reform here in Massachusetts, but it absolutely has been happening over the last 3 years here. Providers believe that they need scale and that they need diversity in order to succeed over time. So you certainly have some of the large provider networks here doing a lot of kind of jockeying to make sure in the musical chairs that they're not the ones left out. And as a result, you see both mergers and, as I said, other types of joint ventures and affiliations. You have the entrance of the for-profit sector. Keith talked about experience of Vanguard here in Massachusetts. We have Stewart Health has come in with Caritas, and that has really changed the market and changed the dynamic considerably. And that really has the other not-for-profit systems opened their eyes and caused everyone to kind of re-examine what might be the possibilities for both for partners with a small p, but for them as well as for how costs might need to be addressed, because Stewart's specific strategy is to be a value provider. In terms of spending in the era of healthcare reform here in Massachusetts, it's interesting. There has been really rising spending on IT. These reflect some trends nationally. There has been some rising spending on outpatient-type facilities and diminished spending on inpatient-type facilities. Again, these are things that are projected to happen nationally and to some extent have certainly happened. The fourth point there about access to capital has been interesting because kind of post-financial crisis and with the capital that's available right now, it actually has not been an enormous impediment, even going down the credit scale with a lot of nonprofit systems. They've had fairly robust access to capital, even though what they're spending it on has shifted. That is not necessarily, as David alluded to, that isn't likely to be a permanent situation, but certainly in terms of cost of capital, there's pretty robust access right now. And then really the big thing that is coming up now in Massachusetts, started last year and really in earnest this year, is healthcare reform phase 2, which is really going to focusing on cost containment. What will cost containment look like? Will it be a market-based set of solutions, heavy regulatory solutions, or some combination? And the broad consensus is that really controlling costs needs to go hand in hand with aligning payments and value, with value, mostly quality. The good thing about the early healthcare reform here in Massachusetts is that by making some of the quality and cost data somewhat transparent, some of the beginning pieces are available and evident to start to make the linkages between cost and quality. there have been several examples. There have been some examples of this that have been interesting in terms of some of the insurers and some of the systems coming up with programs together that work to share, reduce costs, and also to share those savings. Some of those examples have been with Blue Cross and Atrius, which is the Harvard Vanguard system. Stewart and Tufts Health Plan recently has a program that they have rolled out to do the same thing. Partners Health System has purchased the Neighborhood Health Plan, which is a Medicaid plan here in eastern Massachusetts. And Stewart has also had some alignment with Fallon Community Health Plan for some programs to offer networks of individuals insurance as well. So there are a lot of interesting things going on that related to the sharing of costs and how to figure out how to benefit, how both parties can benefit from that. I just have here a snapshot of just the recent state Senate bill that was passed here, and this I'm sure is going to be changed. It's just gone through the Senate. It's going to go over to the House, and there'll be lots of discussion and so on. But just to give you a snapshot of what this the initial version of trying to get a handle on cost containment looks like here for health reform version 2. The state Senate passed a bill. It ties statewide healthcare cost growth to the state's gross state product, if you will. Initially, that gross state product growth plus 5% for the next 3 years, and then equal to gross state product in theory. There's the concept that the state-funded health care programs, these would be the state Medicaid program, Mass Health, Commonwealth Choice, the state employee benefits, would use new payment methods by 2014 that are designed to really give systems incentives to coordinate care for that very large group population in Massachusetts. In theory, the bill has indicated, and the state Senate has made statements that these developments are supposed to be market-based. We'll see how it actually, when there's some meat on the bone and some details, whether they're market-based or a more top-down approach. That's really to be developed as it gets worked through the legislative and negotiating process with all the various stakeholders. There's a concept of a certified, what's called a Beacon ACO, which basically is sort of a Massachusetts state accountable care organization, receiving contracting preferences. There are many other pieces of this bill that expand the role of certain kinds of care providers in primary care, and also continue that concept of trying to provide some transparency for price variation amongst healthcare providers over time. And there's some very modest malpractice tort reforms, not really very dramatic, but some modest changes were put in as part of the package as well. So that's really a snapshot of the Massachusetts experience, and I'm happy in the questions period to answer any questions or provide additional information. And thank you both to Keith and David, and also to Foley for putting the program together.
Well, and thank you, Chris, and thank all of you. It seems a bit overwhelming, I think, the common theme that the structures and models are becoming more kind of abundant in how we think of what our options are, creates a lot of excitement, a lot of opportunities that might be available. We've had a couple of questions come in that look at playing out the model both on for-profit and nonprofit side. Just a reminder to those listening in, at the Q&A tab on the top gray bar will give you the opportunity to ask questions. The first one, Keith, if I can refer this to you, is a question about what for-profits can do to achieve better margins, even though they have significant costs, such as taxes, for example, that nonprofits do not have. Do they jettison low-margin businesses more quickly? Do they avoid poor payer mix communities? Do they take other steps? Your thoughts?
Well, I think, I'm sure you could find one example of every one of those questions or thoughts, but in general, I think if you looked at for-profits in the same profile of business in in a lot of the same communities, many times they still have higher margins. And I think there's a lot of operating discipline on the cost side and a lot of operating discipline on the revenue cycle side. While we see all these celebrated outsourced companies for revenue cycles at hospitals seem to be rolling over their revenue cycles, you don't see any investor-owned companies doing that, because for 40 years, if you go back to an HCA that's been around for 45 years, those have all been core competencies for those systems. So I think core competencies around a lot of the basics and the disciplines of running the business have probably helped that. I'm sure there are examples where for-profits that have aggregated more assets might have better pricing. There may be cases where there are public hospitals present where they have a better mix. It's hard to say, but clearly, we operate hospitals that in some communities are the safety net. But we see differences in margins based on structural issues in a market such as paramix or service mix, and I think geography is destiny first on mix, and then second would be somewhat unique services that you might offer also might drive mix somewhat, such as trauma, for example. And we see wide variations within even the same region amongst margins on hospitals that are generally run at the same level of discipline. So there are clearly structural issues that might change the reason one organization has a higher margin than another. There's many not-for-profits, I would say, that also generate very strong margins, and so I don't think that you can generalize totally. I do think that there are market conditions that will impact what the potential margin could be in a particular hospital.
Thank you, Keith. David, you indicated that private equity could take an interest in not-for-profits. How do you see them exiting that investment?
Well, exit is probably the most important element when you look at choosing a for-profit partner. And you have to really choose your partner very carefully. And there are some distinct differences between aligning yourself with a financial sponsor or a private equity partner versus a strategic partner, for example, Vanguard, a publicly traded company. The first is investment horizon. The investment horizon for a private equity investor, a private equity firm, is 5 to 10 years. Vanguard is much longer. Return metrics are different. Keith's shareholders and board of directors will focus on earnings, growth, and stock price. A private equity investor will look at something called multiple of investment capital. In other words, how many, if I put in $100 million worth of equity capital, what multiple of that will I get back when I monetize my investment? And with respect to exit strategy, which is the point of the question from Baptist Healthcare, exit strategy for a company like Vanguard has much lower importance than a private equity firm, where exit strategy is very, very critical. And I think this is where not-for-profits, to the extent that they're looking at partnering with a private equity-funded organization, has got to focus very carefully on the types of exits that the private equity firm will want, and they will want it. And we've seen it across the board. They could exit via selling their interests, recapitalizing with another private equity firm, which is something that happened with Vanguard, and perhaps Keith could speak to that. They ended up with a different mix of private equity investors when they went public, on the eve of their going public versus day one. The private equity funded company can go public and enjoy broader access to capital. We've also seen models where the not-for-profit partner has the right to buy back the hospitals that are housed in the private equity growth company. An example of probably the most prominent one over and above Stewart is Ascension, who a year ago announced a joint venture with Oak Hill, which is a large private equity firm, and together their business plan is to go out and acquire distressed Catholics, and with that particular strategy, Ascension has the right to buy back any hospitals that were acquired by this private equity funded for-profit. So it's a critical question. It's one that has to be looked at very, very carefully, but it's one that has been successfully negotiated with the models that have been publicly announced, and for those that we are working on confidentially. Keith, I would actually invite comments from you on that, because you were both during the history of Vanguard, you were both a private equity funded company, and now you are a publicly traded company.
Well, David, thanks. I mean, that's correct. I think that, first of all, our original investor, the Morgan Stanley Capital Partners Fund, are still in and still happy shareholders at 14 years. And the Blackstone Group has been almost 8 years, who's our largest investor. And, of course, management's been in 14 years, which is actually the second largest investor group of the former private investors, and obviously the public owns about 40% of the company. But really, as you go public, you start to begin to develop what would be perceived as a more permanent capital structure. But I will say that a lot of the newest private equity funds being raised, the investment horizon's longer, and the time to sell the asset after they stop the investment horizon is also longer. So the idea that these are 2-year, 3-year, 5-year things is not really very accurate anymore, and I think you'll see a lot longer money on the private side as these funds get bigger and bigger and continue to need to raise money. Holding companies on a longer period of time is actually what some of these business models are morphing themselves to. So we're very comfortable in both environments. We're comfortable going in between them, and to us it's just a matter of what at the time is the more efficient way to do things.
Thank you. Thank you both. We've had one question come in from Ziegler Inc. For David, although I would also throw this out to Keith as well, and that's, how do you see the future evolving for standalone community hospitals that might be in more rural markets where there's not a larger system or regional referral center in geographic proximity to be a possible partner?
Let me first share a couple comments and then hand it over to Keith and address the larger question of independent community hospitals, regardless of location. From our perspective, every independent community hospital should be asking themselves whether or not they have the scale to compete and succeed. Organizations that enter into partnerships while they are strong have greater leverage and draw much greater interest from those who try to hang on too long. Those independent hospitals that do decide, after careful consideration, to pursue partnerships should clearly understand the objectives they seek to fulfill and identify a relationship that will fulfill these objectives. In other words, don't take the first phone call that comes in, but rather sit back and conduct a disciplined evaluation of what competencies you need in order to succeed in the long run. We also believe that highly integrated relationship models are required to realize significant cost improvement and strategic benefit. Lastly, and perhaps most important, culture eats strategy for lunch. Culture eats strategy for lunch. Be sure to carefully gauge compatibility. Make sure that there is a fit between the hospital and your partner, whether the partner is for-profit or not-for-profit. And I think that those comments apply to independent community hospitals, whether they happen to be urban-based or rural. Keith?
Thanks, David. I would certainly echo the culture eats strategy, and we you know, as an acquirer, in many cases, we look the same. Or when we're looking at partnerships, we have the same evaluation ourselves. I think the standalone rural hospital that doesn't have anybody to partner with, you know, is a challenge. Obviously, you have a whole pool of critical access hospitals. Some of these are going to just take more cost to prop up. I mean, the biggest concern I see with these organizations is actually around the access to human talent, physicians, other trained clinicians, and the supply. You know, younger folks tend to be aggregating more in urban areas. And I think that's one of the bigger challenges. You know, the idea in the old days of a surgeon, general surgeon, or a general practitioner doing surgery, moving out to a rural area and being a 24/7 on-call surgeon is probably not realistic anymore. So I think the concept of having smaller rural hospitals have a partner which has where patients can be seamlessly transferred back and forth depending on acuity, and you can have the access. I think that's a really good thing. In cases where there isn't a regional referral center, that I believe there's a lot that can be done to help some of these hospitals with relationships with organizations in what I think is an exploding area, which is in telemedicine. I think we're going to see a lot more telemedicine solutions to help triage and diagnose patients where we don't have enough scale and to have the talent we need in the local markets with transfer protocols. And that may not require a hospital necessarily to give up its independence or to quote-unquote partner with a referral center that's close by, but it may require them, if they're more remote, to partner with one that's further away. But I do think there will be a lot. I think technology is on our side in terms of tools for these organizations not to be isolated, because I think the death knell of isolation is the clinical and the human talent isolation, not the bricks and mortar, really.
Thank you. And there's just a few more minutes. I'd be curious if each of you could spend 1 minute discussing to what extent you think the degree of regulation will impact financial markets and whether there's any particular development on the regulatory front that is a particular concern, maybe with respect to financing. Chris, do you have any thoughts on that?
You mean regulatory? You mean financial regulatory reform or healthcare?
Or
reform?
health reform.
Health reform.
Well, either or, I guess.
I think that part of what we've talked about here is kind of this. Even as organizations are more cost constrained and are going to be increasingly more cost constrained in the future, there's also this kind of bursting of additional potential funding sources through alliances and alternative organizational structures. So whether that's, again, the non-for-profit side reaching out to the for-profit side, or different types of same nonprofit, two different types of organizations coming together. So I think a lot of it is trying to distribute capital more efficiently by having partnerships that allow access to capital across organizations, and then where the organizations can then work out a way to kind of share the benefit for that effectively. And that's a lot of that benefit sharing has to really be discussed and analyzed carefully, but I think that's true for access to capital as well as we're going forward.
Thank you. David?
Yeah, I don't think financial regulation means jack squat right now. I think the thing that hospitals should focus on is maintaining their financial strength, and to the extent that they're viewed as viable organizations, that they will have access to capital. I think the larger threat is the threat of taking away tax exemption. I think that's a greater threat than financial regulation of the financial services industry. Hospitals have been, not-for-profit hospitals have been under attack at various points in time over the past decade by both local, state, and national officials as to why they should continue to enjoy the benefits of tax exemption. And there are a couple scenarios in Congress based on the elections that can dramatically change that dialogue, and it also has a lot to do with the future financial condition of cities, states, and the federal government. We all know about the trillion-dollar deficits that we're accumulating every year, and the national debt being what, 12 or 14 trillion dollars. But that's overshadowed a lot of the stress that states have been under, who are required to balance their budgets, as well as cities and counties. So I think the threat of a set of county commissioners deciding to focus on a particular successful not-for-profit and questioning why they don't pay property taxes is a greater threat than anything that Treasury or Congress may be doing to J.P. Morgan or Citigroup or Goldman Sachs.
Thank you. Keith, any final thoughts?
Given we're about out of time, all I would say on capital when you're looking at partnerships is what we talk to partners about is to the extent we need to have people with some financial alignment and some skin in the game. But if your partnership is just a new platform level and you still need to grow, preservation of all capital access as much as you can for the growth versus using capital for the partnership itself is a much better idea. So, we encourage finding creative ways to create the financial alignment and integration in a lot of cases, and using that step is not one that's incredibly capital intensive, so that you can pool capital resources to continue to grow and compete. And that's all I would have to add.
Well, thank you, and thank you all. It's very informative and educational. We are out of time here. I wanted to, the slides are going to be posted, but I would like to let everybody know about the future programs. As I said, this is the first in a series. The next one's going to come up in September after summer vacations, and it's going to be a case study of an acquisition of a nonprofit healthcare system by for-profit organizations. So it kind of dovetails on some of the models that were discussed today. And thank you, everybody, for calling in. The copy of the slides will be available on our website, the Foley website, within 2 to 3 days. You can see the link online here. And we also welcome your feedback. So we'll leave this up for a few minutes, and if you don't mind, we'd appreciate getting your comments. Thank you all. Bye-bye.
Ladies and gentlemen, thank you for participating in today's conference. This concludes the program. You all may disconnect and have a wonderful day.